This program is brought to you by Stanford on iTunes U at Stanford University. Please visit us at itunes.stanford.edu.
Tonight we'll go over a number of topics with low back pain. We'll cover the epidemiology of low back pain, how common it is in the United States, what the current rates are. We'll also look at why low back pain occurs, review some of the relevant anatomy, and look at some common causes of low back pain. I'll also talk about diagnostic tests. This is a big point of confusion, especially in my clinic. Do you need a test? Why does your doctor order one? What are the different tests for low back pain? Medications are always something that's important to talk about. What are the choices available for medications? What are the risks and benefits associated with the different medications? And how important it is for you to inquire about these things when you talk to your doctor. I'll end the lecture with going over some specific pain conditions that might cause low back pain. And then I'd like to discuss common questions that occur routinely in my clinic, and I think hopefully you will find helpful in us reviewing here. Looking at the epidemiology of low back pain, we know that 2 out of 3 Americans will suffer from low back pain at some point, bad enough that it would require them to see their primary care physician. Low back pain now is the second most common symptom leading to a visit to a physician, with the number 1 symptom being respiratory tract infections. Males and females are affected about equally. The most common age for low back pain is approximately age 30 to 50. Low back pain now is the number 1 cause of work-related disability in patients less than 45 years old. And there are a variety of risks associated with low back pain, including heavy lifting, twisting, a sedentary job, deconditioning, and obesity. We know that there's a wide variety in diagnostic and therapeutic approaches associated with low back pain. However, we also know that there's been excessive diagnostic tests ordered for low back pain. It's been reported that up to 85% of low back pain cases never actually have a specific diagnosis. And the cost of low back pain, well over 20 years ago, in 1984, was a staggering $16 billion. So this is a very important issue. The most common cause of low back pain is actually a very simple cause. It's just simple muscle strain. Why do muscles get strained? There's a couple of different reasons. Most common is deconditioning. The muscles have just gotten weak. The other cause of muscle strain is trauma, in which the muscle is overloaded. A perfect example is you've just lifted something too heavy. There's a wide variety of other causes of low back pain. These include a herniated disc, narrowing of the spinal canal. This is something we refer to as spinal stenosis. Growth of new bone in the spine or the hips. This is what's referred to as osteoarthritis. Slippage of the vertebral body, something known as spondylolisthesis. Fractures in the spine, either in the pars interarticularis or a compression fracture of the vertebral body. Inflammation, such as bursitis in the greater trochanter or ischiogluteal region. Looking at the human spine, usually most people have 24 movable vertebrae, 7 of them in the neck, in the cervical region, 12 of them in the mid-back. This is your thoracic vertebrae, This is where your ribs come off. And then 5 in the low back or the lumbar region. In most people, there are 9 fixed vertebrae. These are in the sacrum. 5 in the sacrum and 4 in the tailbone or the coccyx. The lowest intervertebral joints in this are the largest, and they bear the heaviest loads. When you look at gender differences, the lumbar curvature has been found to be slightly more pronounced in females. This is known as lumbar lordosis. It's a natural curvature that you might see in your low back. The sacrum is less curved in females. A lot of my patients ask me, what is a disc? Because we talk about the intervertebral discs and herniated discs very often in spine medicine. I like to think of discs as a jelly donut. These donuts bear the load of your spine, and they're found between the bones or the vertebrae in the spine. As we grow older, the donuts start to dry out, and they weaken. And when they weaken, they're more prone to herniate. The donut's function is really as a shock absorber of your back. The lowest discs are the strongest. And the donuts, or the outer portion of the donut, is called the annulus, and is made of multiple sheets of collagen. The inner portion of the donut, or the jelly portion, is called the nucleus pulposus, and it's rich in molecules known as glycosaminoglycans. The outer annulus fibrosus has very thick, coarse collagen lamellae, and these are, again, the outer portion of the donut. They withstand very high tensile stress, and we believe that the outer portion of that donut is innervated by very small nerves called Sharpie's fibers. The inner portion of the annulus has finer collagen lamellae, and this is a portion that surrounds the jelly portion of the donut. The inner portion, the jelly portion, and this inner annulus are have a very high water content. The annulus is actually designed in a very ingenious way. The collagen fibers are arranged in parallel sheets, and they spiral in oblique opposite directions, almost in a crisscross pattern. This gives that donut additional strength. As we grow older, there's a lot of things that happen to the donuts, unfortunately. In a young patient, the nucleus pulposus comprises approximately 50% of the cross-sectional area of the intervertebral disc. It is very rich in glycosaminoglycans, which have a very high affinity for water and distributes the weight over the larger surface area of the vertebral bodies extremely well. As we age, these glycosaminoglycans become reduced, and their affinity for water decreases. This leads to drying of the discs. As these dry discs take pressure, they're more likely to fissure and herniate. As you see, once the outer annulus gets weak, the jelly can more easily herniate through the rings and then irritate the spinal canal as well as the spinal nerves. This is a wonderful study. This was done by Nachemson, and it's roughly 30 years old. What it is he looked at how disc pressures change with different positions. So to your far left is a pressure of someone, a patient, lying flat on your back. And you can see that the intradiscal pressure is very, very low. You can see as they stand up, the discal pressure goes higher, and it's even higher when they lean forward. That's one of the reasons we ask you not to bend forward and lift something heavy if you've had a herniated disc. What's more interesting is you can see on the far right, someone is sitting, and you can see that the intradiscal pressure goes higher when they sit and lean forward. That's one of the reasons we like to have patients extend or lean backwards when they're sitting at their workstation because the interdiscal pressure goes much higher when you lean forward, like over a computer, like driving. Two very common things and problems. The worst thing you could possibly do is lean forward and lift heavy weight. You can see to the far right that the interdiscal pressure is through the roof. A lot of my patients, when they come to our clinic, will ask whether or not they need a test. A lot of times, just to review for you, physicians order tests to confirm a diagnosis. The diagnosis is based on clinical suspicion and obtained from the history and the physical examination that you should have had with your primary care physician or your spine doctor. It's not unreasonable to try conservative measures and treatments before ordering tests if the physician feels that it's safe to do so. Diagnostic tests are usually ordered to help plan a treatment for you. There's a lot of different tests out there, and it is very confusing for everybody, especially the patients. The two main types of tests that are out there are imaging studies and electrodiagnostic studies. The different and most common imaging studies which are used today are plain X-rays or radiographs, CT exams, the MRI, and bone scans. Radiographs or plain X-rays are a very, very good way of identifying fractures or osteoarthritis, which is a formation of new bone. With X-rays, low-dose ionized radiation passes through your spine and your back and shows the bony structure and the alignment. The deficiency of X-rays is that soft tissues are not well seen. X-rays have a lot of benefits. They're usually low in cost. They can be obtained very quickly. The AP and lateral views demonstrate alignment in disc and vertebral height, body height, and can give a gross assessment of bone density. In addition, oftentimes in our clinic, we will have our patients bend forwards and backwards with the X-rays. These are called flexion extension views, and that's so we can get quickly rule out any instability. The problem with X-rays is that you cannot clearly visualize the soft tissues. X-rays are radiation exposure, and in my patients who are female of childbearing age, sometimes we'll forego them if we feel it's appropriate. And X-rays are not the best for detecting infection or neoplasms, as those would show up late. X-rays are pretty good for detecting compression fractures, but the problem with the X-rays in detecting compression fractures of the vertebral bodies is that it's difficult to figure out if the compression fracture is old or new. Another type of diagnostic study is the computerized tomography, or the CT scan, which you've probably heard about. With the CT scan, X-rays are passed through the body at various angles and are detected by a computerized scanner. A two-dimensional slice of the internal structures of the spine and the back are then created. The CT is very, very good for identifying bony structures. And sometimes your doctor may want you to have some IV contrast of iodine injected. This is to enhance structures. CT exams are fair for detecting herniated discs, but again, they're excellent for detection of osteoarthritis. When you look at CT exams and looking at spinal stenosis or narrowing of the central canal or the spinal canal, it has fair sensitivity and good specificity. Studies with CT exams are unfortunately varied. CTs are moderately good for detecting foraminal and extraforaminal nerve roots. Basically what that means is CTs are not bad at looking at the holes through which the nerves come out of the spine. CTs are very good for facet arthropathy or looking at osteoarthritis in the joints of the spine. Magnetic resonance imaging, or MRI, is probably one of the most common tests that we order in our clinic. The MRI is excellent for evaluating tissues and nerves, muscles, ligaments, and blood vessels. The MRI has the capacity to differentiate between bone and soft tissues and fluid-filled spaces by the content of the water in those structures. The way the MRI works is that the equipment creates a strong magnetic field around the body, which is strong enough to temporarily change the water molecules. Radio waves are then passed through the body to detect the changed molecules as they revert back to their normal state. And this resonance is captured by the computer and processed. A two-dimensional slice of tissue being scanned is then formed, which is, you can see on the right there, a picture of the MRI of the lumbar spine. MRI is excellent for evaluating soft tissues, muscle, fat, liquids, and nerves. It's relatively painless. It requires minimal preparation. But one of the problems that I see with my patients is that if you have claustrophobia, it is a little bit much to take because you will be in a tube for quite a long time. Patients who have any metal in their body, such as pacemakers, metal fragments in the eyes, a spinal cord stimulator, intrathecal pump, a new cardiac stent in your heart, or metal, such as brain loops or stents, should not have an MRI, and you should speak with your physician before having any test like this. Just to recap for you, the MRI, or magnetic resonance imaging, is excellent for soft tissue contrast, excellent for visualization of the discs and the ligaments, good for looking at the vertebral marrow and the contents of the spinal canal. The CT is most likely a better test for looking at bone. This was a wonderful study. This was published in the New England Journal of Medicine in 1994 by Jensen. In the study, 98 normal patients without any back pain at all were examined by an MRI of the spine. The results were evaluated by two neuroradiologists. What they found was 2 out of 3 people, or 67% of patients, who were older than 50 years old had multiple abnormalities on their MRI test. 1 out of 3 people less than 50 years old had multiple abnormalities on their test. And 64%, almost 2/3 of patients, had some type of a disc herniation. So this means that just because you see something on the MRI, it doesn't mean it's clinically significant. Most people will have abnormalities on the MRI test. So you really need your physician to help guide you as to what's relevant and what's not relevant. Other types of tests that we sometimes order are called electrodiagnostic studies. An example is EMG, or electromyography. With EMG, the physician will assess the electrical activity in the nerve and the muscle. Very fine needles are inserted into the muscle to measure electrical activity. And then the activity is recorded and analyzed for sign of nerve or muscle damage. It's not the most pleasant test. It can be painful, but we try to minimize that as much as possible. Another form of electrodiagnostic test is the nerve conduction study. This is used to assess nerve damage. In this study, the doctor uses 2 sets of electrodes, one which is a stimulator and one which is a recorder. An electrical current is given, and then the nerve's electrical signals are recorded and analyzed for abnormality. The final test that I'll be reviewing is called the bone scan. Many of you may be familiar with this. Bone scans are used to diagnose and monitor infection, fracture, and disorders in metabolism. A small amount of radioactive material is injected into the bloodstream and collects in the bone, especially in areas of high abnormality. Scanner-generated images are then sent to a computer to identify specific areas of irregularity in bone metabolism. I'd like to kind of shift gears here and now talk about some specific pain syndromes that we see in our clinic, and there are specific causes of low back pain. I think one of the most common causes that we are aware of is the term sciatica. Many of us know what it is loosely, but when you really think about it, you may not be so sure. Sciatica is irritation of the sciatic nerve. The sciatic nerve is made of different nerve roots, L5, S1, and S2. Often, sciatica is secondary to a disc herniation, and it's usually characterized by pain which shoots from the back into your foot. Symptoms of sciatica are quite characteristic. Oftentimes, our patients will complain of numbness, a pins and needle sensation. They may lose sensation. They may have weakness in the leg and the foot. And they oftentimes will have leg and back pain. The management of sciatica depends on the size of the herniation and the clinical symptoms that you present with when you see your doctor. If you are managed conservatively, oftentimes your physician may prescribe anti-inflammatory medications. Other modifications include changes in your lifestyle and workplace, avoiding heavy lifting. If you work in heavy construction, you may want to avoid some of the activities you normally do. If you work in a position where you're sitting all the time, bending over, you may want to change the way your workplace is set up for the reasons that we discussed earlier. If you do a lot of driving, you may want to get a low back pillow for your car so you're not leaning forward all the time, which would put more pressure on your disc. Physical therapy is also very helpful for lumbar radiculopathy or sciatica. And for patients who don't do well, we do perform injections of steroid medicine into the spine under X-ray. There was a nice study a while back which looked at what happens to disc herniations if you just leave them alone and do nothing. Most mild disc herniations will heal on their own in approximately 6 months, as long as you don't do anything to make it worse. That's not all of them, but that's most of them. If you are having progressive weakness, if you've lost control of your bowel or bladder function, if you are unable to function, it may be very reasonable for you to see the surgeon. There's a lot of other causes of low back pain, as you can see here, and we're going to go through these one by one and hopefully make some sense of them. Spondylolisthesis is a disorder in which the vertebral body has shifted either forwards or backwards in relation to the one below it. It can be secondary to degenerative changes in the spine, or it can also be secondary to a small fracture. When you do have a fracture, most of those patients, or an isthmic spondylolisthesis, have had the fracture since birth and they're congenital. Although every now and then in our clinic we will see very active patients, such as cheerleaders, volleyball players, football linemen, tennis players, who will have a traumatic pars fracture. The treatment of a slippage is based on whether or not the slippage is stable when you bend forwards and backwards, the signs that you have, weakness, and the symptoms. Many times, patients with slippage or spondylolisthesis will need a surgical referral. For those patients who are not surgical candidates, we do manage them with physical therapy. We do very specific types of exercises for these patients, focusing on spinal stabilization. Bracing is something we don't normally do in our clinic for a grade 1 or grade 2 or a low grade slippage. Sometimes we also will use medications, modalities, and if there is central canal stenosis or narrowing of the spinal canal because of the slippage, we will sometimes use epidural steroid injections. Spinal stenosis is narrowing of the spinal canal. This may be secondary to a slippage, such as spondylolisthesis, which we just discussed, a disc herniation, or osteoarthritis. With spinal stenosis, conservative management includes physical therapy. Oftentimes, patients with spinal stenosis will have relief when they bend forward, and the pain gets worse when they bend backwards. Because of this, we usually do a flexion-based program with our therapist using that phenomenon. So there's a lot of abdominal stretching and strengthening. We do some isometrics and short arc extension and core strengthening. Medications, again, are trials of anti-inflammatory medications, neuropathic pain medications, modalities such as ice and heat, and then, of course, the epidural steroid injection, which we perform in the ambulatory surgery center under X-ray. Joint arthritis is a very common cause of axial low back pain, or pain that does not radiate in the distribution of a nerve root. Conservative management of spinal arthritis includes physical therapy. The physical therapy for spine arthritis is different than that of spinal stenosis. Here we try to focus on stretching and strengthening of the extensor muscles, the muscles in the back. Oftentimes these go into strain and spasm as a result of the arthritis and become weak. Of course, there's medications, modalities. We can and do inject steroids into the joint itself under X-ray, and we also can perform neurotomies or lesioning of the nerves which go and innervate the joints. A very common cause of low back and hip pain is trochanteric bursitis. This is inflammation of the hip joint outside of the hip bursa. It's often misdiagnosed as sciatica and usually occurs after some type of trauma, but not always. It's more common in the elderly population. Trochanteric bursitis is treated best through physical therapy with stretching of the iliotibial bands, strengthening of muscles around that inflamed bursa, and also correcting any leg length discrepancies which may occur. Trochanteric bursitis is also very, very effectively treated with ice. Heating an inflamed bursa may feel good for an hour or two, but it will actually make the condition worse. Medications such as anti-inflammatory medications may be helpful, and we also do perform steroid injections right into the inflamed area if these things don't help. Lumbar strain is, as I mentioned before, probably the most common cause of axial low back pain. The muscles which are most commonly affected are the extensor muscles, or the muscles that make you go backwards. These are the erector spinae, the quadratus lumborum. Another muscle group is the hip abductors, or the gluteus medius muscle, which is also very commonly strained, especially in our patients who do a lot of sitting, which is a lot of people in the Bay Area. Medications for lumbar strain include anti-inflammatory medications, muscle relaxants at times, but we try to avoid narcotics or opioids. As I said, the medications are muscle relaxants and anti-inflammatory medications, and sometimes we do perform an intervention which is called a trigger point injection, which is an injection of local anesthetic into the strained muscle. This is usually to make the muscle relax and facilitate a good outcome with your physical therapy. Physical therapy is probably one of the best treatments for muscle strain. Through physical therapy, we usually start with very specific exercises called isometrics, which is basically strengthening the muscle without any joint movement. The reason we start with isometric exercises is because it puts the least burden and stress on the muscle fibers. We progress then to concentric or shortening, and then eccentric or lengthening exercises. The emphasis is always on spinal extensors and hip abductors. We also, the therapist should work on a spinal stabilization program and also work on your postural biomechanics. Sacroiliitis, or inflammation of the sacroiliac joint, is relatively an uncommon cause of low back pain, oftentimes misdiagnosed. Sacroiliac joint irritation is usually secondary to some type of inflammation or osteoarthritis. It's rare. It is more common in patients who've had a pregnancy with a vaginal delivery, some type of trauma, or motor vehicle accident. There are some patients who have spondyloarthropathies who are also at higher risk for developing inflammation of the sacroiliac joint. Oftentimes with sacroiliitis, we treat it with medications, occasionally opioids, but very rarely. Again, physical therapy is a very, very good treatment for sacroiliitis, in which they stretch out and mobilize the SI joint, work on pelvic stabilization. For our patients who are pregnant, a sacroiliac joint belt is also very, very useful. And for patients who don't respond well to the conservative measures, we do perform injections of the sacroiliac joint under X-ray of steroid medication. A common cause of buttock pain is piriformis strain. The piriformis muscle is an external rotator of your hip. Usually piriformis strain is characterized by focal pain, which is really in the buttock region, does not usually radiate too far past the knee. Physical therapy is very effective for piriformis strain. Usually it's stretching and strengthening the external rotators and internal rotators, and modalities such as ultrasound may be very helpful for piriformis strain as well. These are some pictures of patients stretching the piriformis muscle, and these are piriformis stretches. For those patients who don't respond well to the conservative measures and therapies, again, we perform injections of local anesthetic in which we make the piriformis muscle relax under X-ray, and then we get our patients into physical therapy immediately thereafter. I'm going to end the talk reviewing some common questions that a lot of my patients have about low back pain. I think one of the most common questions is, do I need medications? The advice I'm going to give to you is kind of the same advice I'd give to a family member. You need to consider a lot of things before you start using medications. The most important thing is that all medications have side effects. You should know what those side effects are before you start the medication. Your doctor should review the side effects before you take the medication. I know that seems like a simple thing to say, but a lot of patients don't know or ask. So you should be aware of those things. Another very important thing about medications is you should take them as prescribed. If you take a medicine twice a day, which is meant to be taken 3 times a day, you won't have a therapeutic effect. If you take a medicine 3 times a day, which is meant to be taken twice a day, you could have a toxic effect. So it's very important that you pay attention to the side effects and how your doctor wants you to take the medicine. You should always ask your doctor before starting a medicine how long you should expect to take the medicine. Is it for a month or 6 months? Is it for a year? You should know this before you start. Oftentimes I'll tell my patients that it's a good idea to maybe try it for 4 weeks while you're in physical therapy or something like that. But you should know what the big picture is with the medicine. You should know if it's safe to take that medicine with the other health issues that you have. A lot of people don't know that anti-inflammatory medications can increase your blood pressure, and they can increase your chance of having a cardiac event. You should know those things. And a lot of times when I go over the side effects of medications, a lot of my patients don't want them anymore, and that's their right to do so, and you should know that. You should know why you're taking the medicine. It's a very fair question. I think sometimes we just do or take whatever the doctor gives us, but it's very good for you to be informed as to why you're taking the medicine. What is it? How is it going to change your disease process? What's the rationale behind taking it? Very important to know. And one of the most important things is, will your insurance cover it? I think that Everybody can relate with insurance coverage nightmares, and it's a good idea to get that result before you leave the doctor's office rather than at the pharmacist. One of the most common medications that we use in pain medicine are the group of medications known as the non-steroidal anti-inflammatory medications. The reason we prescribe them is because they decrease pain and they decrease inflammation. They should be taken as directed, and when you do take non-steroidal anti-inflammatory medications, and examples are ibuprofen or naproxen, you should take them as directed, and you should take them for at least 5 days before they will reach therapeutic levels. So sometimes patients will say, I took it once or twice, or I took it for 2 days. Well, that's really not enough because you don't know if it's working or not. You need to know that anti-inflammatory medications can interfere with your heart. You should use caution if you have a history of heart disease, heart attack, high blood pressure. Anti-inflammatory medications can also be toxic to your kidney. So if you have a history of kidney problems, you need to ask your doctor. Many times if a patient is on non-steroidal anti-inflammatory medications for a prolonged period of time, more than 6 months or close to a year, it's reasonable to have your kidney function tests through your doctor's office. Not only is it reasonable, it's probably important and appropriate. You should also know that non-steroidal anti-inflammatory medications can adversely affect your stomach, and they can cause ulcers and they can cause gastritis. Another group of commonly used medications are the muscle relaxants. A lot of patients will want muscle relaxants because they feel that it may give them instant relief. There's a lot of different muscle relaxants, as you can see here. There's the antihistamines, there's central alpha-2 agonists, there's depressants of your nervous system, and there's some muscle relaxants which are like antidepressant medications. My take on muscle relaxants are you want to be very, very cautious when you use them. The reason is a lot of them have side effects of dizziness, drowsiness, and confusion. The studies have shown that a lot of the muscle relaxants don't work that well after about a week. This is based on a Cochrane database review. It was a meta-analysis. The studies have also shown that muscle relaxants work a little bit better when we give them with anti-inflammatory medications. This study here was published in 2003, looked at cyclobenzaprine, the trade name is Flexeril, actually found that the low dose was just as good as the high dose, but had much less side effects. So it's important for you to know what are the side effects with muscle relaxants, whether or not you really need them, and what you should be prepared for. A lot of my patients, I will recommend that they use muscle relaxants maybe on a Friday night or on a Saturday when they don't have to drive, when they don't have to work, when they may not have to take care of their children by themselves, and definitely when they're not operating some kind of heavy machinery or equipment. It can be catastrophic. And where I trained back in Boston, we had a number of cases of older folks who just fell and had a lot of other traumas because of that. So you want to be very, very careful with muscle relaxants. They can be helpful in short-term acute lumbar strains, but we don't prescribe them that often. A lot of my patients will ask what changes they should make to their workstation. We talked about this briefly before, looking at the changes in the disc and how the disc changes as you bend forward, as you stand up, as you lift heavy objects. In general, you want to keep extended. You want your computer monitor at eye level so you're looking straight at it. It's good to take breaks while you're at your job. Avoid prolonged sitting. When you look at this, our lady here, and you can see that she's kind of in the middle there. The problem with her workplace right now is the fact that her computer monitor is far too low, and she should be looking back, and that could be the difference between the third column from the right and the second column from the right, which is pretty significant difference in the pressure. A lot of my patients will want to know how long they should rest after a bad muscle strain. There's been some studies. This was done by Deo, and it was published in the New England Journal of Medicine a long time ago in 1986. But basically, the rule of thumb is if you have a bad strain in which you don't have any weakness, numbness, tingling, loss of bowel or bladder function, but just pain in the back, it's very reasonable to take about 2 days off of rest. More than 2 days, probably not going to help you that much. Acupuncture is very, very popular in the Bay Area. A lot of our patients request acupuncture. A lot of patients want to know about acupuncture. There's been a number of studies done on acupuncture. This is a Cochrane review which was published in the journal Spine in 1999. They reviewed 11 trials of acupuncture and found that acupuncture wasn't all that effective. Before that, there was a consensus statement by the National Institute of Health, which was published in the Journal of the American Medical Association, which found that acupuncture actually was useful as an adjunct to acute low back pain management. So basically, their conclusion was when you use acupuncture, it can be very helpful if you do the other things that your doctor prescribes. Personally, I found acupuncture to be extremely useful. The reason is it has a very good risk to benefit ratio, meaning the risks are relatively low, the benefits are pretty good, and I like those kinds of things because they're low risk to my patients, and that's the most important thing to me. A lot of patients and therapists will talk about traction. The goal of traction is to relieve muscle spasm, to treat muscle strain, and to enlarge the neural foramen, or the holes through which the nerve roots exit the spine. Unfortunately, there's not a whole lot of good evidence to support this. Traction is definitely contraindicated in rheumatoid arthritis and osteoporosis. There was a meta-analysis which was published in 2006, again in the journal Spine, looking at 24 randomized controlled trials, well over 2,000 patients, and the conclusion was that there was no evidence that traction is useful in the long-term management of low back pain. We do need more quality studies. Some patients do benefit from traction. The problem that I've had with traction is that some patients have also been injured from traction, and because my patients go to so many different therapists, I can't ensure what type of traction and what kind of treatment you're going to have. So in general, we try to avoid traction because based on the literature and the articles so far, there's no evidence that it has long-term benefits. I think this is probably one of the most common questions that we get in our clinic, and that is, I'm worried, could this be cancer? Cancer is extremely rare. Looking at the studies, this was published in 1997, of all visits to the primary care physician, less than 1% are actually metastatic cancer, probably closer to 0.7%. However, some red flag signs of cancer or metastatic cancer include weight loss, anorexia or loss of appetite, pain which is worse at nighttime and is worse when you lie flat on your back. If you have any questions or concerns about cancer, you should definitely follow up with your primary care doctor about that. A lot of my patients want to know what's safe for them to do and what's not safe for them to do. Obviously, it's a very difficult question to answer because it depends on the diagnosis of the patient. Your doctor that you're seeing for your back pain should be able to give you some guidelines about what's safe and not safe. But it's a general rule of thumb in our clinic, if you're doing an activity and you're having pain which lasts more than 3 hours or even into the next day, you've probably done too much. And you need to decrease the intensity and the duration of the activity. Usually what I tell my patients is by half. Another very, very common question, do I use heat or do I use ice or do I use both? An easy way to remember this is warm up, cool down. Usually we use warm, moist heat before stretching and activities. The reason we do this is based on some old studies that doctors did in the 1950s, in which they heated connective tissue, and the connective tissue they used were rat tails. And they found that the rat tails actually stretch out much more when you heat them. And since then, we've found that the same principle applies to muscles. And that's why we always heat the muscles before, and then we ice them down afterwards with a cold pack for about 10 minutes. You should be very careful. A lot of my patients will sleep on an ice pack or sleep on a warm pack. I don't recommend you do that because you can get burned from both. So you always, if you do use ice, you should wrap it in a towel, and you should never apply a warm pack or some type of electrical pack to your back for more than 10 or 15 minutes. A lot of my patients will want to know whether or not they should wear a back support or lumbar support. This was a study done by Riddell, and it was published in 1992. Basically, they looked at airline baggage handlers, and they wanted to know if the airline baggage handlers who had back supports did better than the airline baggage handlers who didn't have back supports. The punchline of the study was that there was no difference. We've found that people who use the lumbar supports for long term actually can weaken their back, and it can lead to atrophy. There are some conditions in which the lumbar support can be helpful, such as a compression fracture, but those are rare. In general, we do not use lumbar support for an acute strain. A lot of my patients want to know why they should see a physical therapist. I think I'm probably biased with this slide because I have found that physical therapy is a very, very good treatment. Physical therapy often treats the problem. It increases your function. It increases your strength. And what I like is it has a very favorable risk-benefit ratio, meaning that the risk to you, if the physical therapist knows your diagnosis and follows the instructions from the doctor, should be very low, and the benefit should be very high. And it's for these reasons I really do recommend physical therapy for a lot of the conditions that we see in our clinic. Not all of them, but many of them. It's good for your doctor to work with your therapist, and the best way to do that is by having a therapy prescription, which is something that we provide in our clinic at Stanford, which is detailed with the diagnosis, what the exercises should be, how long they should be for, and whether or not you need any modalities, such as heat or ice or ultrasound. A lot of my patients will call, and they want to know if they should go to the emergency room or they should not go to the emergency room. Very common question. It's difficult to answer, but there are some red flag signs and symptoms that we always counsel our patients about. New weakness, that's usually a problem. Losing control of your bowel or bladder function. I don't mean bladder incontinence, which happens as you grow older, but something that's new and that is very severe. Inability to walk, a fall or a trauma, any loss of consciousness, paralysis in which you cannot move, severe pain which is not responding to some of the conservative treatments that I've spoken about earlier. If you're unsure, you should definitely call your primary care doctor's office and talk to the person on call. It does not hurt to call and double check. A lot of my patients will want to know whether or not they should see a surgeon. It is a very complicated decision, and oftentimes your primary care doctor and your treating doctor can help make that decision with you. Potential symptoms which may warrant a surgical evaluation include progressive weakness, the loss of bowel or bladder function, a change in function, or severe pain. Again, if you're unsure, you should talk to your doctor. Second opinions. I think a lot of our patients are unsure of whether or not they should get a second opinion. They are also, a lot of patients feel bad about getting a second opinion because there is some sense of loyalty to their doctor. My recommendation of getting a second opinion is that everybody is entitled to a second opinion, and if you're not sure or you're not trusting your doctor, or if you have not gotten your questions answered, if you've not reviewed all of your options, you should definitely get a second opinion. because it's your health and it's your back. And doctors are used to getting second opinions, so you shouldn't feel bad. And it's fine to just say, I think I'd like a second opinion, or I'm here for a second opinion. Nobody is going to think badly of you if you do that, because we understand that this is important enough that it's worth getting a second opinion. That ends the talk. I wanted to entertain some questions. Then while we talk about the questions, there are some websites which may be very helpful for people. These are websites which have very good resources for low back pain. The first one you see is from the National Institute of Health, and they do have a very nice low back pain website. The other two are from the American Academy of Orthopedic Surgeons and the American Academy of Physical Medicine and Rehabilitation, both excellent resources for low back pain. What are the thoughts on chiropractic manipulation? Chiropractic manipulation, we don't work with chiropractors in our clinic. We don't have a lot of good data showing good long-term efficacy of chiropractic manipulation. In that light, if you do want to see a chiropractor, I think it's up to you. There are some manipulations which may put you at risk, and I would definitely talk to your chiropractor about what are the risks and the side effects of every manipulation that you're having. And I think that's a very reasonable thing to do, because anytime we do something in our clinic or in the operating room or in the ambulatory surgery center, we do go over all of the risks. And I think that the biggest problem in healthcare, not only for chiropractors but also for physicians and other healthcare providers, is that the patient is not informed enough. So the most important thing you can do is probably ask about what's the worst that could happen if you do this or do that. Neurotomies are lesioning of nerves. Basically, when you have arthritis in the joints of the spine, those joints are innervated by very small nerves. They're called medial branch nerves. In a neurotomy, what we do is we find those nerves under X-ray using a high-frequency probe, and through a series of testing, we lesion the nerve. Basically, we destroy it. So it's no longer able to transmit the pain coming from that joint. The neurotomies in general last for anywhere from 9 months to 1 year, but they are at higher risk of having some kind of an injury to the spinal nerves. We do everything we can to make sure that that does not happen. The alternative to having a neurotomy or a lesioning of the medial branch nerve is simply doing an intra-articular injection of steroid or injection of steroid medication directly into the joint. So both of those things are options. So there's two questions. The first question is sitting, and whether or not there's activities such as swimming which can decrease the adverse effects of prolonged sitting. Usually the problem with sitting and prolonged sitting is the fact that it's not so much sitting for a day or a week or a year, but it's sitting for your career. So basically year after year after year, you're hunched over a computer. As you remember from the slide, the intradiscal pressure is higher when you bend forward. Swimming can be very helpful, but it's not going to really counteract the problem. It's not addressing the problem. The best thing to do is really modify the workplace in which you're extended and you're not bent forward over the computer, because if you're extended, the intradiscal pressure will go down dramatically. The second question was, is it better to sleep flat on your back, or is it better to sleep on your side? Well, unfortunately, when you're asleep, you're probably going to be unconscious, so it doesn't matter what I tell you. But based on the slide, it does look like that the intradiscal pressure is less when you are flat on your back. Now, that being said, I don't think it's considerably less, and I don't think it's going to make a big difference whether you're on your back or on your side. The biggest problems that we see is when people are sitting forward and lifting heavy objects. So a lot of my patients will ask whether or not they should get a specific type of bed or they should buy a fancy bed. I usually tell them to buy something that's in their price range and that's comfortable, because the intradiscal pressure, although it's different, it's not significantly different. If you've had a spinal surgery or lumbar fusion, how would you know if the fusion has failed? Usually, we see a lot of patients who've had spinal surgery. Oftentimes, we do a full workup, including some flexion extension films or x-rays with you bent forwards and backwards, looking for any slippage in the transitional zone or the zone above and below the fusion. The other thing that we look for is changes in your symptoms. So if you have new numbness or tingling or weakness, if you're falling down, so those are things that we would pay attention to, and it would prompt a new workup. So how do you know if you have a problem with your fusion? One, the most important thing would be new symptoms, which you didn't have shortly after the fusion. And then you would need to see your orthopedic surgeon or neurosurgeon who performed the fusion surgery, or your spine specialist who you're seeing. The type of mattress that you're sleeping on, can that affect your back pain? There is no good medical study to show any mattress is better than any other mattress. So I would recommend you pick a mattress which is comfortable and in your price range. So the question is, do we have some exercises that we like to prescribe for prevention of lumbar strain and low back pain? The answer is yes. We have a whole variety. We have a library in our clinic which we give to all of our patients. If you have a special interest, we can definitely get you the exercises as well. There are a series of diagrams. If you also are interested, we'd be happy to examine you and write out very specific therapy prescription, which is what we do for all of our patients, in which we write a custom therapy prescription. It's a very good question. Is there anything that can be done to delay drying of the discs? Probably the most important thing is to make those modifications early on in your life, such as avoidance of heavy lifting and avoidance of bending over a computer for prolonged periods of time. Now, that being said, if it's too late, it's too late. There is some work that's being done. It's not a treatment yet, but at the last national conference I was at last year at the American Academy of Physical Rehabilitation, there is some work being done with stem cell and regeneration of the disc, but that's not ready yet. The question is an open MRI just as good as a closed MRI? The resolution with open MRIs traditionally has been much more poor than the closed MRIs, but recently, in the last 2 years, there's been a number of open MRIs which I've been very, very impressed with the resolution. And nowadays, I don't even think twice about having a patient get an open MRI if that's what they need, because in my experience, it's better to have an open MRI than nothing. And secondly, the open MRIs, the resolution has been very, very good. So the question is there a relationship to footwear or injury to your feet and low back pain? That's a very good question. And the answer is absolutely. There is a relationship between your feet and your back. In rehabilitation medicine, we refer to something called the biomechanic chain. It's a principle that we learn. And basically, the principle is very simple. Everything is connected. So if you have an ankle fracture, it's going to affect your knee, and your knee is going to affect your hip will affect your back. So likewise, if you do have a disorder of the foot, either let's say plantar fasciitis or arthritis in the ankle, and if that is not treated, it definitely will affect the rest of your body.
The preceding program was brought to you by Stanford on iTunes U and is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at itunes.stanford.edu.